So good evening, everyone. Welcome to today's Fireside Chat, number 156. My name is Dr. Yuri H. I'll be your moderator for this session. Tonight, we have an interesting topic on kidney supportive care in children, and we're going to be looking at the African context. Our guest speaker will be Dr. Lyndal Gibbs, who's a qualified pediatrician who had obtained her postgraduate diploma in pediatric palliative care in 2018. She joined the Paeds family 3 years ago and is a team coordinator for the hospital-based service. She also lectures the UCT undergraduate medical students and pediatric registrars. Dr. Lyndal is passionate about providing ethical, holistic care for all children with complex palliative care needs. So welcome to our session today. It will be the third session in the kidney supportive care series. So Dr. Lyndal, over to you.
Thank you so much, Yuri. For our third fireside chat, so snuggle up, grab a blanket if it's cold, and some marshmallows. If you are fasting, you can hold your marshmallows for now. But I'm really excited to join today representing the Africa Healthcare Network, the amazing team I work with at Paeds, and the greater team as well. So we're going to learn a bit about them today. And if this will click, there we go. So just some overviews. We're going to look at some core concepts and advocacy today, some of the principles of kidney supportive care. It wouldn't be a complete talk if we didn't speak about our teams, and also some practical applications of kidney supportive care and how we do it in our setting. I'm not going to look at acute kidney injury, acknowledging that is a massive issue, but Mignon and her team are covering that with the Saving Young Lives initiative. There's lots of initiatives around that already. I'm looking more at the children with chronic kidney disease. Unfortunately, a lot who had missed the boat acutely. And I have no conflicts of interest to declare, but many people to thank, who I will thank at the end. So just to start, Erin covered this a few months ago, so I won't go into too much detail, but just to remind ourselves what pediatric palliative care is. The WHO has an incredibly long definition. It's about a page long, but essentially it's the active total care of the child's body, mind, and spirit, including support for their family. It's a concept which is applicable from the time of diagnosis right through to bereavement, and needs a very broad multidisciplinary approach. We provide it in many settings, and not only provide symptom relief, but also enhance the quality of life for our patients. Sorry, kids are here. Oh, boy. Thank you, boy. Sorry, can't keep 5-year-olds out the room. And we affirm life and regard dying as a normal process, accepting that it will happen to everybody, including ourselves, and that when the time is right, we need to roll with it. I like the definition in that it feeds very nicely into the concept of universal health coverage, which really covers a lot of the advocacy work that is happening around kidney care. Universal health coverage states that all people should have access to the full range of quality health services they need, when and where they need them, without financial hardship. It covers the full continuum of essential health services, right from health promotion and to prevention, treatment, rehabilitation, and here we are, palliative care across the life course. And every year on the 12th of December, we celebrate UHC Day with a different theme each year. The problem with this, it sounds beautiful, is that we're not winning. So in terms of universal health coverage, the WHO is a bit bleak about it at the moment, because the world is off track significantly to make progress towards the goals of UHC by 2030. They estimated that in 2021, 4.5 billion people were still not covered by essential health services. 2 billion of those people faced financial hardship, and 1 billion experiencing catastrophic out-of-pocket health spending. That's massive. Even a third of those are people going even deeper into extreme poverty due to healthcare costs. So we are clearly very far from getting this right. Now, to make you more depressed, in terms of kidney care in lower middle income countries, it's quite difficult to find specifically African context things, but across the board, chronic kidney disease treatment is not prioritized. Kidney replacement therapies are very expensive, we know this, And financial resources are dwindling, even in our very resource settings. Healthcare provider shortages abound, with us having about 1% of the pediatricians that the USA does per population number. And there's insufficient healthcare funding, not only from the state, but from families and healthcare funders like medical aids. To make it worse is that there's an increasing prevalence of chronic kidney disease in lower middle income countries. It's estimated that about 7 million people die per year due to unavailable or limited access to kidney replacement therapy. But we actually don't know the exact numbers because there's a dearth of research in the areas that probably need it the most. Depending on where you read it, the numbers vary slightly, but it's estimated that 68% of African countries have no access to kidney transplantation, which makes taking your patient to the definitive point of transplantation really tricky if it's not even available in most settings. And we know that it would be a preferable option instead of dialyzing patients because they will have better outcomes and ultimately less expensive outcomes, but we're not there yet. Another paper showed that 93% of the people receiving kidney replacement therapy live in high or upper middle income countries. So access is a major challenge. And that it's estimated that 1% of patients in sub-Saharan Africa actually continue their hemodialysis for a year, according to that cohort that was studied. To make it even more depressing, there's lack of access to palliative care, which is quite simple and low resource in comparison, especially, as always, for the poor. So how do we make this better? We certainly need to look at our healthcare system and be a bit creative. We need to do things differently because we can't carry on the same way we have and hope for more. If anything, things are going to get harder. So integrating kidney supportive care involves having a synergistic relationship right from preventative care right through to health services providing care for people with chronic kidney disease. It's holistic, it's coordinated, allowing for patients to transition between acute and chronic kidney disease, and it encompasses all of the interventions, including conservative kidney management, transplantation, and dialysis, not regarding one superior to the other. So this speaks really to the palliative care stance as well. To do this well, you obviously need humongous teams, and what we need to do is each bring our best skills to the front. So one of the proposals was that nephrologists have certain skill sets that they should hone in terms of kidney supportive care, and that specialist palliative care comes in with some other skills. So our nephrologists are expected to, and certainly in my setting, do this exceptionally well. Basic assessment of management of pain and physical symptoms, assessment and management of depression and anxiety, which is very common in our patients. Being able to communicate matters such as prognosis, decision-making, goals of care, conflict resolution, and to be able to relieve suffering across all domains. The specialist palliative care team comes in to co-manage things such as refractory pain and physical symptoms, assisting with more complex things like complex depression, anxiety, grief, and often we're involved in conflict resolution in terms of multidisciplinary team meetings between our colleagues, between staff and families, and within families themselves, who often don't see eye to eye. And this speaks to the way that palliative care is evolving across the world to create a setting where there's universal services that are provided by all. There's those core palliative care concepts which sit there in the middle of that triangle, which should be provided by actually all healthcare providers. And then there's a few patients who would need specialist palliative care interventions. In our setting, often the patients will have a trigger event or some crisis where we are needed, and they might go on for months and years where they actually don't need specialist palliative care, and that continues to be provided by their primary team. And that might be within the hospital, it might be in their community, and their needs obviously will be constantly assessed, making sure that we're reaching what they need at the time. So it can be a little bit overwhelming when you're looking at integrated kidney supportive care. It's not just as easy as going, okay, phone palliative care, they'll come chat to the mum. We also need to think about all of the other factors, which we need to make sure that are being addressed properly. Child rights, family issues, socioeconomic status, which is a massive thing in our setting. ensuring that our patients are nutritionally appropriate, that they're safe, that they have access to things like water, education, that they can reach healthcare systems, that they're not paying fortunes out of their own pockets. And all of those things come together to make sure that we're providing proper holistic care for our patients. Now, that seems like a lot to cover in your clinic visit. But fortunately, as healthcare providers, we're not the only people who have to do this. So the picture on the right, you can see that the community plays a huge role, research, patient organizations, policymakers, et cetera, with healthcare workers being part of that bigger picture. Doesn't mean we can slack and allow other people to do it, but it does mean that we can do this with the support of a greater team beyond just our clinic or hospital. When I was reading all this literature, because my confession is when I give a talk, I go diving deep into the literature and I try to read as much as I can. And I felt quite overwhelmed. You know, all this policy stuff, all of these huge numbers that we're not achieving, these fortunes of things that we need to do for our patients, it can be quite overwhelming. And even when you're looking at the sheer numbers of patients who might be coming through your unit, where do you start? So Paeds is recently rebranded and we have elephants as our picky. And I thought, how do you eat an elephant? So the trick is to not eat the elephant, obviously, but people will often say one bite at a time. But if you alone try to eat that elephant one bite at a time, you're going to get a tummy ache, aren't you? So the trick is to have a whole team to help you bite the elephant. So this is my team from Paeds. This was at our year-end function last year, and you can see there's quite a variety of people. So just walking you through from the back to the front, we have a social auxiliary worker, pediatricians, our admin team, a nurse, aromatherapist, art therapist, fundraiser, music therapist, social worker, transport people, family counselors. And my boss is separate from this because she was off doing advocacy work in America when we had our gathering. And advocacy comes in as well. So that's my team who help me daily to nibble on the elephant that is our work. But that's still not enough. You need a bigger team. So there's this good looking bunch as well. Thank you, Mignon, for the pickies. At Red Cross, we have nephrologists. We have multiple kinds of specialists. We have specialized nurses, dialysis techs, urodynamic study people, urologists, an incredibly humongous ICU. We have lots of bells and whistles. We have gadgets that you can't dream of in many places. And yet it's still tricky for all of these people to be able to nibble at that elephant. So how do we do this? Yeah, just for context, we're not struggling in Cape Town compared to many places. I have a beautiful hospital. We live in a beautiful city. And yet, year by year, we see things become increasingly challenging. Budget cuts, resource cuts, our patients struggling more hunger, more poverty. So even with the best resources, it's still difficult. So when we're providing that kidney supportive care, instead of looking at that massive picture and being like, oh my gosh, this is too much for me, I can't do all of this, I'm just not going to do anything. Go back to the basics, go back to the groundwork. These are the components of kidney supportive care that we need day to day. Issues such as shared decision making, even though in our setting very often that is more resource limited. We need to be competent in symptom management, crisis planning and advanced care planning, that we're not stuck at 2 o'clock in the morning phoning Prof. McCulloch, that we have an idea of what this family's wishes are. They'll need spiritual care. We need to integrate with community services, and in most settings, there are amazing services that can help you. We need to think about end of life long before it happens, and we need to have a setup for bereavement. So I'm not going to look at all of these in great detail, but just some of the bites of what we do on a day-to-day basis. Firstly, we have to mind our language. The terminology is changing. The way we speak about these patients is changing. And I love the consensus decision that we rather talk about a kidney rather than renal. People don't know what renal is. They don't know what a nephrologist is. They've never heard of nephrons, but people know about kidneys. So in being patient-centered, we're speaking language that our patients can understand. We're talking about kidney failure rather than end-stage kidney disease. Yes, we know the GFR definitions and such things, but our patients don't. And patients prefer to have a supportive team rather than palliative. So perhaps in the future, we'll be changing what we call ourselves. The terminology also needs a bit more precision. So we need to avoid the bandying around the term untreated when we're referring to conservative kidney management. It in itself is treatment, just not dialysis and kidney replacement therapy. We need to incorporate terms like comprehensive and quality across all of those modalities. And the aim of this is to bring our patients into the conversation. It's to ensure that they're not feeling alienated, that they're not feeling abandoned, especially if you tell a family your child is not for kidney replacement therapy. In our setting, that means that they won't receive dialysis and that they're not listed for a kidney transplant. People often feel really hopeless. They feel like, the hospital's not trying hard enough, that they need to change their circumstances. It puts a lot of guilt and weight onto families. But what we're trying to say is we're still treating your child, just in a different manner. And certainly the literature has evolved quite a lot in the last few years, demonstrating how this language is a lot more inclusive. So I really like it. We need to be able to be well-versed in terms of symptom burden of our children. So it's tricky in kids with chronic kidney disease because about half of them look fantastic. Low symptom burden, running around, going to school, living their best lives. But it's estimated about 50% of them have significant symptom burden. Some of the common ones include pain. Fatigue is a massive, massive complaint from our patients. Nausea, feeling agitated, and going with that often being having insomnia, struggling to sleep. Dyspnea, especially if they're struggling with pleural effusions. Pruritus, these poor kids itch and scratch like crazy. And if their electrolytes are abnormal, tetany is incredibly painful and distressing. Now, in the interest of time, I haven't gone into great detail about how to manage all of these things. But Fenella Craig and her team have put together a spectacular talk. Not a talk, a paper, my apologies. A fantastic paper which goes into great detail about how to look for this, how to manage it, and very importantly, how to titrate your medications that you're safely managing without causing excessive accumulation. The reference is at the end. We also need to watch out, here we're going to feel overwhelmed again, for the comorbidities in our children. They're at huge risk of malnutrition, metabolic acidosis, bone disease, anemia, electrolyte imbalances. They're often failing to thrive or stunted. They can have reduced cognitive ability from being chronically ill. They can't run as far as they could before. And a lot of them are depressed. And interestingly, I learned something here. They're about 1,000-fold increase having risk of cardiovascular disease when age matched to their well peers. So again, when you're seeing your patients in your clinic or you're doing your follow-ups, you need to be screening for these issues and anticipating them rather than waiting for them to become a problem. In palliative care, or shall we call ourselves supportive care, total pain is really the foundation on which we build a lot of our houses. We look at not just the physical pain of our patients, but also the social, psychological, and spiritual components of their pain and suffering. And as doctors, I think we're moderately okay at treating physical pain, but we're not so great at the others. So we need to actually change a little bit about how we practice, how we engage with our patients, to give them space to express their concerns, to bring those pains to the table, and for us then to be able to help them or refer as need be. There are lots of non-pharmacological interventions. In our setting, we use quite a lot of music and art therapy and play therapy modalities, age-appropriate counseling. Kids have questions and they deserve to have them honestly and clearly explained to them. We want to empower our patients. We want to empower our families. It's incredible how somebody who's barely educated can become an expert in their child's dialysis or an expert in their child's condition. We need to give them that opportunity. As I've said, we have to address the spiritual and psychosocial pains they're experiencing. And we can do small things that'll make big differences to improving the quality of life in this pain experience. And we need to mobilize those community-based support structures. We need to also keep an eye on our patients' quality of life. We quite like the Paeds QL version 4 tool, which actually has been validated for use in children with chronic kidney disease. And it looks at the physical, emotional, social, and school functioning. And actually, there's a scoring system so that you can understand the child's quality of life. This is obviously incredibly subjective, but a really valuable thing to be asking about so that you're on top of your patient's concerns. Watch out for the caregivers too. So I was quite excited to read about a pediatric renal caregiver burden scale. They'll probably have to change that to kidney, won't they? Which has been validated in the UK and Egypt, but not worldwide yet. But again, they're looking at assessing financial difficulties, which are very common in our kidney families, the social isolation experienced by caregivers and families, their own poor physical health, where they'll prioritize their child's care over going to their own clinic appointments and caring for themselves. And the massive disruption that happens to families when they have a chronically ill child, and overall a lower quality of life. Our caregivers, again, very often are depressed. And there's some really nice questionnaires that you can use to screen for depression. I've added a link to the one that we use most commonly in our setting. And importantly, another component is advanced care planning. Coming with that is crisis planning. This in itself is an entire workshop, but just to give you a taster, we need to be having these conversations. It's difficult when the kids look well, and we're so scared of destroying this family's hopes of their child getting a kidney, going back to school, all of those things, that healthcare providers really actually suck at this. I'd say across the board, I'm not pointing fingers. But in a study, it was a German study, but we have a similar experience here in Cape Town. Most parents are actually really scared their child is going to die, and they wish for more open discussions. In this particular one, 99% of people wanted more open discussions, and only 21% of the surveyed parents believed that they'd received enough information while their child was alive. So advanced care planning is not a thing that you go, hey, palliative care, we need an ACP. It's a long process involving multiple discussions between the caregiver teams, with the family, with the child, with their community if need be. We need to be aligning our goals of care. We need to be crisis planning for the what ifs. If they become septic, if they get electrolyte imbalances, all the things that could happen to that child. So it's a really personalized process. And in some patients, or many of them in our setting, we'll draft a document to actually guide future care, which helps tremendously for those 2 a.m. decisions, but obviously is not etched in stone long term. I'd love to give another webinar about this sometime. And finally, when you're feeling utterly overwhelmed, remember to be compassionate. So compassion fatigue is actually a misnomer. What we suffer from as healthcare providers is actually empathy fatigue. It's feeling with your family and not being able to actually do something about it. So compassion steps it up a notch. You still have the empathy. We seek to address their suffering and needs, but we do so through relational understanding and action. And herein comes that care that the patients need, and the fact that we're doing something for them. And again, those tiny, tiny things can go a really long way. So to not leave you feeling completely depressed, I'm just showing you some of the work that's been done with patients of ours. So Bihlali was our patient a few years ago, and he really struggled with vague physical symptoms. He'd come in for admissions that just didn't quite make sense. He had this anguish and this pain. And what came out through his art therapy sessions is he was really angry at his dad. His parents had divorced. You see in the picture on the left that there's a wedding ring between the two of them. And he'd hoped for them to get married again, even though they had definitively moved on from each other. And he'd worked through a lot of his rage at his dad, at his own body, at his disease. And after that, his admissions were far less. And he just seemed like a much happier boy. Such a simple intervention. This is little Innocent. He was our patient last year. Beautiful boy who looked absolutely gorgeous right to the bitter end. When you come to our clinic at Paeds Pal, you generally will get spoilt. And if you leave without a toy, then you've done something really wrong, I think. We almost always give our kids a gift as they leave. So here he is with his teddy bear. He made some handprints with his mum that she's now worked on in terms of her bereavement work in the stitching group. And he worked through his emotions through music. And there he is with our lovely therapist, Marie. At the bottom in the middle, he's opening up one of many presents he received from an incredible organization we have here called Reach for a Dream, who really go out of their way to spoil kids who have chronic conditions and who have got life-limiting conditions. What's sad is that he was spoilt with many toys and he died the next week. So I don't know if he got to enjoy all of them, but such a beautiful memory for his mum to carry forward. This is Priscilla. Everybody knows Priscilla. She grew up with us and she grew up in the E2 ward. So she had a very difficult family situation and she'd often come to her appointments by herself, even from when she was young. Her adherence to her meds was scanty, if best, but she just had a fire about her. And I think when she needed to be safe, she would come to hospital. She would come to Paeds Pal. Here she wrote a poem that she was very, very involved in and very committed to. She liked to break the rules, and even though she was not allowed chips and Coke, that was her request. You could not visit her in hospital without chips and Coke. I think she had everybody wrapped around her little finger. She had every nurse in the hospital madly in love with her, and she came for innumerable therapy sessions with us, really just to hold that relationship. And we did cry torrentially when she did die. Here's Asake working through some of her worries that she'd had, again, in a music therapy session. And importantly, just being a child and playing. Our entrance area has got heaps of toys to play with. So the kids come in and they can just free play and do what they want and just express themselves. So it's quite a nice, light-hearted space to be. She felt quite strongly that she wanted to not be in Cape Town for her ongoing therapy. She was originally from Tata, and we helped her arrange with the renal team to get her back to Mthatha with an advanced care plan, with coordinating care with the teams there. And they actually did really excellent end-of-life care for her as well. A shout out to our private funder who also helps sometimes getting patients home, and that was also fully sponsored. And finally, here's darling Mika. He was so excited when I asked him last week if I could share his picture. He's a current patient of the unit. He loves to come across for play with Angela. He's just started doing some art therapy sessions with us. And when he goes into the art room, basically he plays with the doll's house for most of the time, but that's fine. It's part of the therapeutic process. He's a man of very few words. So for him to express himself through these media is so valuable for him and for his family. We do a lot to support this family. His half-sisters have had quite a traumatic background, so they also attend art therapy to work through that. His mum comes by for a massage while that is happening. And where we can, we help him just with some spoils and some transport as well. I could go on about these kids all day, but I will stop there because I'd like to engage with everybody and just bore you with some references. There's some great papers here. And thank you for your attention, especially thanking Ashton, who is a renal rock star, for all your help with this, and Mignon for just opening doors for me and mentoring and supporting me for the last 14 years. I really appreciate it. And I'm really excited to have been here today. Thank you.
Thank you, Dr. Lyndal. That was quite an enlightening talk. And I just want to open the floor to any questions, any reactions from the participants. Just feel free to type your questions on the Q&A chat box. For panelists, you can unmute yourself and ask any questions if you may have. There's one comment from a participant by the name Julia Kirkby, who says, please can you send the reference for the paper addressing the symptom management in CKD, and says thank you for the great talk.
Certainly, I'll add the reference in a moment for you.
Then another participant by the name of Datonya Briggs says, I kindly want to find out how members of the Paeds manage to manage their own mental health in return.
That's a great question. And I think the answer is in different ways. I've certainly this week had a humbling experience of having to manage my physical health, which is never fun. But we know if we don't look after ourselves, our bodies will shout at us. We do a lot of debriefing in our team. At least twice a week, my team and I debrief. We do work with a lot of really complicated, difficult and emotional families. So that's such a valuable part of what we do. If we are having a particularly difficult patient or difficult situation, we'll often do what we call a hot debrief. We will there and then actually just sit down and go through some stuff. I cry super easily, so I generally don't tend to carry like heavy emotional burdens with me. They come out of my eyes. So waterproof mascara is your best friend in this job. And yeah, I think we try to strike balance. So as intensive as the work is, and you have to be incredibly present when you're working with these families. I'll make sure that I go into the room generally with an empty bladder and a full stomach, or at least not being hungry. Making sure that I've set aside time for those families, that I can be present, that we're not feeling rushed. And I think that helps me to really be able to immerse myself in engaging with that family, and helps me to know that when I walk out of that session, I've cared for them as best I can. Yeah, I mean, other things like we do wellness things, so we'll sometimes go walk on the mountain, or we do ridiculous things like go ice plunging into freezing cold seas in the middle of winter. We look after each other, our families look after us, and we're also learning often the hard way to rest.
Thank you for that reaction. There's just a comment from Dr. Mbanefo, who says the main challenge we have is with open discussion with the family members. We have Professor Minon, who says we have been lucky to send some of our teams for online palliative training. I think she's saying whether Dr. Ashton will want to comment on this. I don't know whether Dr. Ashton would want to comment.
Thanks, Lyndal, for a very good talk. I think it's such a massive topic that, I'm not sure we ever get to eat the elephant. There's just so much work to do. Yeah, so there is online training that is available, I think, for some people. But I don't think it really supplements real world experience. I think dealing with patients on a day-to-day basis really is the best form of training. It can be quite overwhelming, but it's really just about involving yourself with the patient, and actually being present in the conversations that you're having with the patient. And like Lyndal said, it's not about one point of contact, it's about multiple points of contact in developing that relationship and developing the care plan. The one thing that from Lyndal that I really do want to stress is that caregiver burnout is a real thing. And often you have these patients that you think they're non-compliant, they're not coming to the party, but you need to take into account that maybe the caregiver is actually just completely burnt out and stressed. So it's something to really consider in your difficult patients. Thank you.
Thank you, Dr. Ashton, for that.
I'm just sharing a link for some amazing online resources. I usually punt our team, actually. So the National Pediatric Palliative Care people, we're called Patch SA. And what started off as a textbook has turned into online courses, which are accessible anywhere in the world. So don't feel limited by South African rands. I've put the link, it's at academy.patchsa.org. And there's all sorts of things from communicating with children to being able to do advanced care planning. What else is there? Symptom management, all of those things. So not kidney specific, some more general palliative care concepts, but really useful things to bring into your work. And if you need CPD points, you get points too. So that's a great way to spend a few rands and get a lot of bang for your buck.
Yeah, thank you for that. Another question from an anonymous attendee says, the question is, what are the main conditions in which palliative care is recommended in your setting, apart from advanced malignancy?
Everything. Yeah, so I mean, I think palliative care, often when people think about us, they think about cancer, and a lot of the literature is around cancer. My passion areas are more around the sort of specialist things, so gastroenterology, nephrology, in critical care, actually. That's my big favorite thing. And I think it depends. I think some patients with really complex conditions can be managed very well by their primary teams, but I think it's when that complexity becomes a little bit more than you can cope with. So difficult conversations, challenging planning, often when you're trying to coordinate teams as well, perhaps between here and somewhere else, we often come on board for things like that. I think importantly, you need to remember that you're not going to send the patient to palliative care, that they're going to work alongside you if you're lucky enough to have a team, and be able to complement the services that are already being provided.
Thank you for that. Another participant is asking, how much information do you advise us to give, especially to adolescents?
Adolescents are brilliant. I think we don't go guns blazing, giving generic information to our patients. What we tend to do is we get to know our patients. We get to understand the language that they're using around their condition. And we want to understand what they want to know. So if I'm giving information to a patient or a family, I'm not going to give them just an info sheet. I'm going to engage with them and understand what they need to know and really try to answer that as honestly as we can. And I must say our adolescents tend to take a lot of control in their conditions. Legally in our setting, they are allowed to make decisions around their healthcare and consent. So they're really important as part of the team. And that said, I've got kids as small as 4 years old who are very involved in their care. So I think we need to involve kids as much as they want to be involved and do it in a way that is appropriate to that child in front of you. I don't think we can answer that generically.
Participant is asking, in which age do you exactly initiate hemodialysis for pediatric patients? Not too sure. I think probably the transition from peritoneal dialysis to hemodialysis. I think that's the question is around that.
I mean, maybe I should answer that, Lyndal. I don't think there's a specific age. We practice, at least in South Africa, peritoneal dialysis first. So we tend to initiate all our patients on peritoneal dialysis. If you have patients where you can't initiate peritoneal dialysis or there's complications and you have to switch, it's really difficult to dialyze anyone under the age of a year and about 10 kilos. So we've generally used that as our kind of limiting kind of step for initiation of any form of renal replacement therapy. But I think it's dependent on where you work and what you're comfortable managing. But generally anyone less than that, just getting hemodialysis access is a very big problem.
Thank you, Dr. Ashton. I think one of the panelists, Dr. Shuk, has just raised a hand. You can unmute, Dr. Shuk.
Good evening, and thank you, Dr. Linda, for a very nice presentation. Mine is a comment and a few questions. I just wanted to know, in case of palliation, who decides that this child is for palliation, and what happens after that? Because in our case, for example, you have a child who is has kidney failure, and there's no funds to support renal replacement therapy. Then it is like one-man show. Unfortunately, we don't have such a comprehensive team as yours, but maybe we'll see 2 doctors and social worker and discuss with the parent, and then it's like informing them, we are sorry, we cannot do this, and maybe because you cannot afford it. Then you'll discharge the patient, but next day when they have difficulty in breathing, they will come back to you. And so the palliation changes, somebody will see and like raise an alarm and start dialysis, and then again you fail to continue. So how do you manage to keep this patient in palliation and making sure they stay in that palliative program in a calm situation, knowing that this is some form of management also? And another thing, I appreciate that your team, you have like almost everybody. And how did you manage to have all these people? Is it the hospital? Is that is how your system works, or it is the efforts of the doctors to recruit those people? If you can be kind enough to reply to that. Thank you very much.
I'll answer your second question, then your first. We are entirely privately funded as an NGO. There is not a single cent of government funding that goes towards us. Several of us are employed as well by University of Cape Town, but that doesn't sort of impact our day-to-day work. So every cent of every salary and running cost is raised privately. So Michelle Mehring, my boss, is an absolute visionary, and she can get blood out of stones. So she has been doing tireless, or actually exhausting, fundraising for over a decade to be able to run this. So, you know, a lot of it is schmoozing. It's private funders and writing grants and reports and things like that. So, I mean, there's been many years of trying to get palliative care properly integrated into the public service. We have in South Africa an incredible policy document, which should have been fully enacted by the end of 2022. But here we sit without the policy document enacted whatsoever, where there should be publicly funded posts. At the moment in South Africa, there is one pediatrician or one Paeds palliative care provider who is paid for 10 hours per week. by the government, and that is the only person. So yeah, it is all private, it's all NGO sector, and that is probably how it's going to be for the foreseeable future, especially as our health system feels like it is crumbling. Going back to how we retain our patients, we don't always win. Some patients just don't come back. You know, you can drag that horse to water, but it might not always drink. What we do see, though, is sometimes the family will say, oh, no, we're not ready for palliative care because they think it's death care. We're not the death people. We're the life people. We will do some end-of-life care, but actually mostly our primary team does it. And most of what we're doing is the other supportive components. So I think once they see the benefit of having, you know, a counselor, the children being able to explore their issues, us being able to help with food and money and all those things, especially in families who are often very impoverished, that helps them to come back. And I think we're quite a nice team as well. So generally they like to come back. But I think it's an advocacy matter that we need to remind patients that it's not just for that day that you're dying or that week that you're dying. Palliative care is a long-standing thing. I mean, I think we knew Priscilla for about 6-7 years. I'd known her since I was training as a pediatrician. A lot of these kids that I manage now, I've known since they were babies. So it's also that relationship. It's knowing these kids. It's knowing their families. Mika, for example, you know, he doesn't really talk to me, but he doesn't talk to anyone. But the other day, he was showing me a lot of pictures of his cats. And we spent half an hour in his room just literally talking about cats. It's great. He said a few words about them. He told me their names, and his dad was telling me about his cats. And that was our intervention of the day. So I think it's really important to not just speak to your patients or engage when things are bad, but also to be able to be, you know, that point of contact and safety for them. And then we have a reasonably good retention rate with that.
Thank you very much.
Thank you, Dr. Shir, for the question. I think the last question by Dr. Lloyd. Question is on children may experience anxiety and depression or difficulties adjusting to lifestyle changes imposed by kidney disease and its treatment. So question is, how do you manage these children who experience anxiety and depression and difficulties in adjusting to lifestyle changes?
Again, it depends on what the appropriate supportive care for them is. So, you know, often our music and art therapists come in there to give the kids just a free space to narrate their own story, to figure it out in their own time. And often they do tend to do that. Or, you know, their parents need to be empowered too, and how to support them. So we do a lot of work on that. Anxiety is quite common. You know, I do quite a bit of work with kids who have needle phobias, for example. And every child is a little bit different. Obviously, you go to the literature on what works well, but you tailor it to that kid. The depression is really tricky because, you know, you have to go, is this their disease or is this actually depression? We do get the psychiatry team involved sometimes as well. And those kids who are depressed, they need supplements, they need antidepressants. And we often see a bit of a turnaround there as well.
Thank you so much. Thank you very much.
If there are no other further questions, I just want to say thank you to Dr. Lyndal for making time to take on the talk. And it was quite insightful, and we're looking forward to more talks. Wish you a good evening. Thank you.
Thank you so much for having me.
Yes, thank you. On behalf
Thank you so
of
much.
Africa Healthcare Network, I want to thank you. Yes, Dr. Lloyd, I'll give it to Dr.
Yes, it's a wonderful session, extremely informative and a lot of learning. Thank you very much, and very touching indeed. The effort and the compassion and the work put in is by the whole team, so coordinated. Thank you very, very much. It's an eye-opener.